This session will be recorded, and so if you are during the Q&A session unmuting yourself or turning on your camera, that will be recorded. If you do not want to be recorded by the camera, feel free just to send your question to us in the chat during the Q&A session, and then we will read it out. I'm here with Mr. Christopher Trudeau, and I'm going to allow him to be introduced by our very own student, Jocelyn Wang, who is a current law student. I think Jocelyn's in her second year, if I'm correct. And Jocelyn is a member of our president's White Paper Project Fellows. And in this, they are currently crafting a white paper of their own on the topic of health literacy as a social determinant of health. And I'm not going to tell you much more about that because I want Jocelyn to tell you all a little bit about what they're doing and then to introduce our wonderful speaker here today.
Yes, thank you so much, Greg. Just a quick intro. Mr. Christopher Trudeau is an associate professor at the University of Arkansas Little Rock Law School, as well as a professor at the University of Arkansas for Medical Sciences, where he teaches health professional students in health law and communication. He is a leading expert on the legal aspects of health literacy and is an executive board member of the International Health Literacy Association. He is also the first lawyer to be appointed to the National Academies of Science, Engineering, and Medicine's Roundtable on Health Literacy. So if you could all help me give a warm welcome to Mr. Trudeau, and also just a quick overview of our project. The fellows are all students from different disciplines, and we're working this year on studying health literacy as a social determinant of health in order to give recommendations to both UMB and UMCP, recommendations on how to improve health literacy education in our respective schools, as well as improving it in our respective communities as well. Thank you.
Well, thanks everybody. I'm going to share my screen now and get started, and then bear with me for 1 second while I get this out of the way. Well, again, thanks for having me. It's really great to hear about these projects. I was just talking just a few minutes ago about how it's so hard to get collaborations, among universities, even if they're part of the bigger system. And we have that here in Arkansas as well. Where the UAMS, where I'm part of, is all part of the University of Arkansas system, and then we have Little Rock, and we have Fayetteville, and we have these others, and it's really hard to get everybody to be on the same page and work towards the same goal. So I'm really happy, to hear that you're doing that. And I've been trying to do that since I've been here for the past a little bit over 4 years, and it's worked pretty well. And I'll talk a little bit about that as I go through. So I work for both of these places. They're not paying me to say this. They don't necessarily condone or my views. They can't publicly do that anyway, so I have to have those disclaimers, but I have no other relevant financial interest in this. Now, here is the research issue that Jocelyn was just mentioning, that they're creating a white paper on. And so I was provided this beforehand, and it really helped kind of shape my talk a little bit. And so let's use this as the framework: is how can the University of Maryland system address health literacy as a social determinant of health and cultivate an empathetic, team-based approach to meeting the community's health literacy needs. So that's just a very broad but great question, because that's one of the things, as I started thinking about this, is this is really a change effort. Anything we do nowadays is really a change effort. But the really good thing about the COVID crisis, if you can call anything good about it, is that we're used to change. We've had to adapt, we've had to grow, we'd have to reduce things. We're improving our delivery methods all throughout this past year for the most part. And so and that's one of the things where I think we're in a better state in terms of change mentality and change mindset than we were a year ago. I mean, I remember this time maybe not this time last year, but a month from now last year, Everybody was worried about teaching online and how that's going to work, and how, I don't know how to teach online. I don't know how it's going to happen, to do group work. But now it's like you just do it and you figure it out and it works. And so this book, I don't even know if it necessarily has as much resonance now, but it's one of my favorite books on change. It's by Chip and Dan Heath, who also wrote Made to Stick, which you might have read that. But they talk about change being like a rider riding an elephant. So you have to shape the path because that makes it easier for where the elephant to go. But the rider is like the logical side of things. So if you have the rational, logical reasons for doing something, then the rider or the driver of the elephant can kind of control where they're going. But the elephant is like that, the barriers, the resistance to change, the fear, those type of things. And so, the rider can help kind of go, have the elephant go down a certain path. But once the elephant wants to go somewhere, it's going to go somewhere. And so that's when I think about change, I often think about that. It's thinking not only about the reasons for change, the rational, logical reasons, but also, what are the barriers? What are the fears that we don't even necessarily articulate? It just might be there. Because if you can adapt that to both sides of things, then that can help. And so really what it is, it's about changing perspective, right? If you are thinking things have to be, one way, and somebody's looking at it the other way, if you can kind of, flip it around and think about how the perspectives might change and how you can mesh them together to make something work for everybody. So this is kind of the outline of my talk for the day, but I'm also using it kind of as a way to kind of think about 3 keys to supporting change for health literacy efforts. So the first one, again, is that logical, kind of practical reason for doing something. So what's the purpose? How does it impact the organization? And then kind of my unique angle on this, and you have different angles, public health angles, and many other types of angles on this, but kind of my unique angle is how can we use laws and policies to support these efforts for change? So I kind of call it the legal hammer, or the regulatory hammer. So if we can align some of those laws and policies with our organizational goals, we can get over a lot of those hurdles. And then, of course, the biggest thing is, okay, we're on board. Let's do this. But how do we do it? How do we implement it in a way that's effective? And so I'll talk a little bit about that at the end. So thinking about the question that we just went through is, why does clearly communicating with people matter for a major academic institution? Not only University of Maryland, Baltimore, but College Park, the whole system. And again, we have the case study of all case studies here. It's, thinking about coronavirus's impact on your system, whether you be in College Park or Baltimore. You would have information delivery across the whole spectrum of what you do, not only for students, but faculty and staff, and you're still going through it with vaccination rollouts and those type of things. I know I get at least 3 emails a day about some type of clinic or something. And so how the system rolls out to just its core of, people is really important. But if we think beyond that, for the hospitals, for the research participants, if you're a major research institution. So the policies, the practices you set up for handling that is very important as well. It's not just, we tend to think about students, faculty, and staff, but particularly when you're such a large institution that reaches so many places, how we communicate with these folks is critical. And then, thinking more about research activities, how does the university or the IRBs within the university communicate with researchers? So I know at UAMS here, we put a lot of our research on hold when coronavirus hit, and everything was kind of, because we didn't know how to deal with a lot of things, we don't want people, we need to consent people, but set up e-consent, and we don't want them to come in for in-person visits. So how are we going to do these remote visits? So we just put things on hold. And getting things back going was kind of difficult because you have to think about the communication roadmaps. How are people now going to figure out how to do things that they were doing in person before? And so there's just so many different things that have been impacted by this. And then think about like community service organizations, within the Maryland area that all depend on their relationship with you and maybe, students, professors, organizations, all of that is impacted by what we're going through and by how you react to these things, since the pandemic, for sure. So if you think about communication, it's now front and center. You can think about how important that is. And so I always start with this almost in every presentation I do, because it's one of the key things. It's like, which of the following is the best predictor? And it's literacy skills, or else I probably wouldn't be here and put the question up. But all of these other things can be, you talk about social determinants of health, age, income, race, and ethnicity, education level, they can all be determinants. But, in one of the studies cited in the American Medical Association, the manual for clinicians back in 2003, it was that really resonated with me and with a lot of other folks is, 75% of patients who reported being in poor health also tested in the below basic health literacy category. So if you've been attending other sessions of the speaker series over the terms, I'm assuming you've heard about health literacy in the various categories, but essentially, you have proficient level all the way down to below basic or even non-literate at all. And the percentages are skewed. There's only 12% of people who really fall in that proficiency category. And then it works its way down to about 36 to 50%, depending on what data you look at, fall into that basic skills or below basic skills. But what's interesting when you think about social determinants is, this kind of infographic this is part of the infographic from my friends at Communicate Health, but older adults. So we think about those in that 60 or 50 plus really are 3 times more likely, to be in that below basic category. So the lowest level of maybe being able to read an appointment slip, those type of things. Hispanic Latino adults, 4 times more likely. And then again, the self-fulfilling prophecy of poor health, people in poor health are 5 times more likely to have below basic health literacy skills. And so this, again, is a cycle that just keeps, dragging people down. And so one of the things we did, and I will talk a little bit about this, as it relates to Maryland in a second, but one of the things we did in Arkansas a few years back was we used the health literacy data map, which was created, it's housed at least now by the University of North Carolina, but it was created by them and others. And we use this to kind of map the counties in Arkansas. And so this is what Arkansas looks like. And if you see the part where that's in dark green and then the hash green, that's called the Delta region. So that's the Mississippi right on the right-hand side of that. If we were to overlay this with all other types of disparities, economics, college graduation rates, high school graduation rates, crime, those type of things, it would look very similar to this. And so again, that is the problem, is that the folks we're trying to serve have many other issues besides just literacy. And so putting our resources into those areas can pay dividends for sure. And here's what it looks like, again, from the data map. It looks a different key, of course, but in the Baltimore area, you can see the red is the worst and the green is the best. And if you look at this, this is very common in many major metropolitan areas. You have these deserts of literacy deserts. And if you were to think about these in terms of like access to services and those type of things, you'd find those similar deserts. And so again, it's kind of interesting when you break the data down kind of to more of a granular level, and you could even break it down even further than this. And so that's the problem we're dealing with. But one of the things that I know Dr. Bauer has probably mentioned is this idea of clear universal precautions for health communication. You don't know who has low health literacy. You kind of can get some ideas of the population centers as a whole who might need help, but you really don't know. I mean, it's very situational. If I remember, my mother had was diagnosed with breast cancer over 5 years ago now, which is great. I was, I wasn't there for the first visit, but then when I went back when she would need her mastectomy, I kind of was there for the visits, and I know a little bit about this area. I'm not a trained MD, but it's an area I think about and read about. But when you're thinking about how to clean a port and how to do all these other things, I was like, wait, now how do I do this again? Trying to help her out. So everybody has issues when it comes to learning new things. So for me, if I were to teach you all about some area of law, you might have PhDs, you might have masters, you might even be second-year law students, and you might not know what I'm saying, if I don't do it in the right way. But again, COVID-19, everybody on earth has had to learn about that since, December of 2019, right? When it first the scientists were first starting to see these cases in China. And so think about, from my kids, my little kids, all the way up to the most elderly, we've had to learn about this. Nobody knew about it. And so we're always trying to teach people things. And that's where clear communication comes into play. So from now switching a little bit more towards my legal realm and kind of the things that I deal with a lot at the medical school, and, is how do we create better forms and processes to make it easier for people to navigate our system? Because again, it's a big system. We're focused on healthcare, but all of this can work with public health and with social services, all of these things. There's always going to be forms. There's always going to be processes. Well, in this is probably one of the first major studies in this from 1995. They found from patients from 2 public hospitals that 86% of people didn't understand the rights or responsibilities section of the Medicaid application. So again, the legal language about what you're supposed to do and what your rights are and what you have to do in order to get Medicaid. And then 60% of people didn't understand a standard informed consent form. I mean, the study was large, so it covered a lot of other things. But these are the 2 things that really relate to kind of that policy in the legal realm of things is when we're communicating this information. How do you receive a benefit? How do you pay or get a tax break or have to pay into some government program or something like that? How we explain these things is of critical importance because we know many people will not get the message. So one of the things I spend a lot of my time on now is working with our researchers and our IRBs to kind of create, not only consent forms, but also, all things related to research and clinical trials, in trying to put those things in ways that are easy for people to understand. So we know that most consent documents, at least historically, have been written at a really high level. 10th grade or above, when you think about, the average U.S. adult reading level falls in that 7th to 8th grade, depending on the study. I just kind of round up a bit there. And so we know there's a disconnect there. And so one of the research I've been doing just now, actually, I'm writing the article as we speak. So I just came, not as I speak, but right before I spoke, I was writing this article, and still I'm going to be writing the article the rest of the month. But some of the data I just came up with a few weeks ago is I looked through all of their 765 informed consent forms on clinicaltrials.gov that predated the revised common rule, which I'll talk about in a little bit. And I kind of ran them through readability statistics and those type of things. And we see, there's 60% of those that are above the 9th grade level. And so we know people, again, read at about the 8th grade level or below. And so the vast majority, and then another 32% that are above that other level, 10th grade. And so we're having a lot of disconnect there. And even though we've had some movement in the positive direction, because it used to be 10th grade, now it's working down a little bit more, that's a positive thing. But my word of caution is this: readability scores do not equal understanding. So I kind of use it as a guide to see, are we going in the right direction, or is it going in the wrong direction where it might be too difficult for people to understand? But the problem sometimes is that folks say, okay, we're just going to make everything, at a readability level of a 6th or 7th grade. And then it's going to solve all our problems. Well, that's not true, because I could write a sentence that, if I know how the calculators work, I could write a sentence that you wouldn't understand that is in the 5th and 6th grade level. It could be, gobbledygook, just be not follow any of the syntax or anything else. But it would meet the calculators. So the calculators are misleading, but in some ways, but they help you see if you're going in the right direction. And the other problem with that is that, the calculators typically only look at the prose. I find this works pretty well with legal documents because, lawyers, we write in prose for the most part. But it doesn't, the calculators don't work very well with forms or other documents that you have to, calculations you need to make quantitatively or in, kind of this interpersonal relations, discussions that you have. And then for things on the internet, all of these kind of come into play, whereas the calculators, they mostly focus in on what do the words say, not all of these other things. So that's kind of my caveat, is that, plain language or writing clearly is a small concept that's part of this bigger concept of clear health communication, clear health literate communication, which involves so many other things. So that's kind of, my setting the stage for, why this matters, especially from a legal and a regulatory standpoint. But again, I can't really focus just on the legal side until you figure out how the public health justifications and the business justifications, kind of fit in. So again, this is what I'm always, talking to companies and others about, is how would this benefit you if you made, clear health communication kind of your way of life. And this is a 2015 Accenture study, and they found, they focused on this from a patient engagement and customer experience standpoint. But, the idea that clear communication, carefully crafted, processes that people can follow, strengthens customer experience, and it correlates to a higher margin for hospitals. So that's a plus. And then same thing with the hospital. They were thinking, well, a hospital system earning $2 billion in revenue would have to cut 460 jobs, assuming a $100,000 salary with benefits, to achieve the same 2.3% margin benefit that improving the customer experience might bring through revenue growth. So that focuses on hospitals and getting paid and money and those type of things, where that's certainly a part of academic institutions, no doubt, especially if you have a hospital and those type of things, like we do here. But just the customer service aspect of running an academic institution and connecting with all of your community is important. And so if you could benefit, if you could improve that, how does it benefit you in the long run? That's kind of the idea there. And same thing from a 2016 study from the SCAN Foundation. Again, they focused on, patient-centered care, and I'm abbreviating here. Patient-centered care results in a greater sense of empowerment, a focus on wellness and quality of life, and a better care experience. There's also evidence that it improves the job satisfaction of healthcare providers who enjoy connecting meaningfully with patients and working as a team. So if you're in the health world, and you know about the triple aim, which is now the quadruple aim of health areas, that's what patient-centered care does. Is it focused not only on the patients, but also on the quality of life for the providers as well. And the same things happen, for public health organizations, for social service organizations. You can make things better through kind of customer-centered, approach to things. And then again, from a business standpoint, this is kind of, if you think about reimbursement rates, Medicare pays the hospital a certain amount for a hospitalization based on the person's diagnosis, regardless of length of stay. So when a care program, a patient-centered care program shortens the stay, the hospital gets the same money, but at lower costs. And so they get a higher return. So the point of that is there is an economic case to this as well. I've spoken for our Arkansas Board of Health in the past, and one of the things, this was you can see by the date, this was pre-COVID, but one of the things we're focusing on with childhood obesity is this idea of increasing breastfeeding of infants. In Arkansas, we have, we're usually in the bottom of a lot of these things. And so that's kind of the cool thing about being here, is there's a lot of positive change you can make. Excuse me, I'm coughing here. So thinking about these evidence-based barriers to breastfeeding, most of them have to do with social determinants, not only lack of knowledge and education, that whole communication type of thing, but social pressures and norms, support systems, how do you employment and childcare, how do you do it when you're employed and you put your kid in child, how do you still breastfeed, all of these other things. And so these are, from a public health perspective, many of the social determinants have a component of clear communication that goes in there and awareness and those type of things. And so you really can't disassociate clear communication with any of these efforts that you're trying to do. So again, and then now this is really why I'm here is to talk about the regulatory trend towards clear communication in health law and policy. And that's what I've been doing, the last couple of years, is kind of tracking how things have been changing, over the last decade or two. And it really has, there is this trend towards understanding or putting in understanding requirements in various laws and policies. So I say understanding instead of health literacy because they don't always use the term health literacy, but they use things like in words a person or a patient or whoever it is for the service could understand, and so again, you can't do that without, thinking about health literacy. So there's UN policies, there's national action plans, US has one, there's US federal policies, state policies, all of these international laws. And then there's actual laws in the US that really focus in on understanding requirements. So the UN has called for the development of appropriate action plans to promote health literacy. And this has spawned, because that was about 2009 or 10, I believe. And that has spawned a lot of movement in this regard. So, we have our own national action plan that came out in 2010. We had the Plain Writing Act of 2010. Scotland's on version 2.0 of their national action plan. You've got Germany and Portugal that have come out with some recently. Canada, Netherlands, Singapore, Ireland are working towards it. They're at some level of a policy statement, but not quite at a national action plan. And even China, they were the first policy mention of this back in 2008. So there's a lot of support from a policy standpoint. And even from the U.S., government standpoint, and this is, I like this. I mean, this has been carried over in some degree to other iterations of the Health and Human Services strategic plan. But this one, I love just this quote here: using clear and productive communication strategies, improving the experience of care for patients, caregivers, and families, integrating health literacy principles, and promoting patient self-management. So you'll see that no matter what it is you're trying to do, you're going to be able to find some policy statement on a federal level and mostly on a state level as well that supports what it is you're doing. So rural health, for example, is a huge issue here in Arkansas because we're a largely rural state. But the CMS's rural health strategy, discusses or encourages collaboration with rural community networks to develop and disseminate easy to understand materials to help rural patients navigate the healthcare system. So how we do the outreach and how we communicate here is really important. So we might not be the right messengers. A lot of times it's beauty parlors and barbershops and churches that help get out the message, but we do create the pamphlets and the handouts and those type of things. And so kind of testing and working with those in the community can help make sure these messages resonate when we go out there. And Dr. Bauer played a role in this, I assume. I don't know this for a fact, but I assume when she was at the CDC, she played a role in this. But the CDC has long been a huge champion of health literacy, and you can see, that they've have goals to develop and distribute health and safety information that's accurate, accessible, actionable. And this last year has been very difficult because we're learning on the fly. But again, I think the CDC has done a fine job. I mean, we can always nitpick and say, oh, they should have done this or they should have done that. But in the changing environment, did a good job getting information out there, especially with the states. Every states are all over the map, but looking to see, okay, this is what the CDC has said. That has guided a lot of decision making. And so without kind of that framework that's been, that Dr. Bauer set, for a decade or so. I don't think it would have come across as well. And so starting to look at regulations and accrediting standards. So again, if you're talking about, a hospital in the UMD system, if you want to get reimbursed by Medicare and Medicaid, you have to follow the CMS conditions of participation. That's kind of what it's called. And these are long, thick binders of rules and regulations and those type of things. But I love, because I'm a dorky law professor, is to go through these manuals and find things that support what it is that I want to do. And so if you think about it, and so here's an example. For example, long-term care. A long-term care resident has the right to receive notices orally and in writing in a format and a language that he or she understands. And then they describe a language that the resident understands as communication of information concerning rights and responsibilities clear and understandable to each resident. And so again, this is something where you can't do those things if you're not incorporating, health literacy concepts, thinking about the social determinants of health and the other barriers that your particular audience has. You won't do it effectively. And from a litigation perspective, for the lawyers in the room, there's not a lot of actual cases. There's not a lot of cases that use the term health literacy. There's some in Hawaii, for example. When things are not written in Japanese, or what's written in English when somebody else only speaks Japanese. There's a couple of cases like that are out there. But this is one where some of my friends at some of the major insurers in the country have taken notice of this. This happened in 2014, and it was the result of a denial of benefits letter, and so the language, the denial was just very basic in some parts, and then it was just too hard to figure out in other parts, and so somebody appealed, was denied the appeal, and then it got into this litigation, and the long story short was they settled. And part of the settlement requires the Louisiana Department of Health to describe specific reasons for denial in plain language and in sufficient detail to know the denial rationale. And then the settlement document actually defines plain language as language that the intended audience can readily understand and use because the language is concise, well organized, and follows best practices of plain language. This is perhaps the best legal document that's publicly available that actually talks about what it is we do. But again, talking to some of my folks at the insurance companies, they said, well, we use this actually to kind of make sure that, when we're trying to do our change efforts within our insurance company, that this is the worst case scenario. We don't want this to happen. And so let's make it clear. And again, more regulations, home health, conditions of participation. So a patient's rights notice that includes the right to actively participate, to develop and update their plan of care and discharge. And it needs to be written in plain language. Now, this is fun because I love to talk about informed consent, but this is something where, again, with hospitals, CMS has said this, is informed consent requires that a patient have a full understanding of that to which he or she is consented. An authorization from a patient who does not understand what he or she is consenting to is not informed consent. So that's a great statement for me to use when we're thinking about changing consent forms. And then here's one from the Joint Commission. And again, not recent. This is from 2007. So we've known this is a problem for a long time. And so again, this bashes my own kind, and I kind of like it. Informed consent forms that are written by lawyers for lawyers do not increase the knowledge of those who, with their signature, are committing to allow the performance of treatments and procedures that may be associated with significant risks. The typical informed consent form is unreadable for any level of reader, and I wholeheartedly agree to that. And even the Affordable Care Act, there are actually 4 direct mentions of health literacy in the Affordable Care Act, and to some extent, some of these have not really been implemented very much or enforced at all. But there's other sections like Section 1557, which you may know as kind of the discrimination section of the act. But it also talks about low English proficiency, which and how you should communicate clearly with those. And you really need health literacy principles in order to do that. So there's really, you can find almost anything. And then again, from a plain language perspective, we have the Plain Writing Act of 2010. Now this only applies to federal agencies, and it really doesn't have a penalty for not doing it. But because of kind of the advocacy efforts of the Center for Plain Language in DC, they've come up with report cards that you probably have seen in the on the internet or in papers over the years that kind of say, oh well, HUD is doing horrible. I don't know that. I'm just making that up. So if you're from HUD and you did well, I apologize. From a state-based perspective, though, it's kind of interesting. And so I looked a little bit in Maryland, but these CARE Acts, for example, my home state of Michigan, they have passed a CARE Act, which focuses on caregivers, and AARP has been helping to push this out. But almost all of these acts have something to do with, culturally competent communication, plain language, health literacy, and you can see that from Michigan. And then Arkansas, we have one as well. And they have the duty to educate the caregiver concerning the aftercare of the patient in a manner that is consistent with current accepted practices and based on the learning needs. And Maryland is not alone. Maryland is part of this. So effective October 2016, you can see, one of the requirements is you give live or video instructions of the medical or nursing tasks you will need to perform at home to the caregiver. And again, they kind of, the actual act talks about, kind of the language and the requirement. But then as I was looking through this, I found this Maryland Cultural Incompetency and Health Literacy Act of 2012. And so that made me think, do you have a duty to do these things? This actually doesn't put the duty on you, but it talks about the government, working collaboratively, the state government, I should say, working collaboratively, easy for me to say, with universities and colleges of medicine, nursing, pharmacy, dentistry, social work, public health, and allied health. So all of the people that are part of this project in the state and other healthcare professional training programs to develop courses with cultural competency, sensitivity, and health literacy that are designed to address the problem. And then it kind of explains further things. So that made me think, well, if you need any type of support for what it is you're doing, you have it right there. I mean, at least from an educational perspective, you have a statutory call to focus on these things and develop these type of programs. So I thought that was kind of pretty interesting. And so you may have heard about the GDPR. Even if you haven't heard about the General Data Protection Regulation, if you've gotten online at any time in the last 2 years, you've had to click the box, right? Click a box about the privacy rights and all of this. Well, that's because of the General Data Protection Regulation, which is an EU law, but since everybody's on the internet all over the place, it comes up for the most part all the time. But what I love about the act is they really do care about clear and plain language, and they say so in some of the guidance documents. And so here's some good quotes. When seeking consent, organizations should ensure that they use clear and plain language in all cases. This means a message should be easily understandable for the average person and not only for lawyers. Again, I love bashing my kind. Organizations cannot use long, illegible privacy policies or statements full of jargon. Now, one thing I think that I haven't seen many policy statements directed at children, but this one is awesome because, again, it's given that children merit specific protection, and we know they get on the internet. Any information and communication we're processing is addressed to a child should be in such a clear and plain language that a child can easily understand. So you really can find anything that, something to support you from this regulatory and policy perspective. And from the clinical trials and drug development side, since that's the big talk now with vaccinations and those type of things, is the EU has a lay summary requirement, which says, well, you need to take the study results and put it in language that people can understand. So that way, not only for the people who join the study, but the public can know what it is you're doing. And so that has led to a lot of trainings and a lot of development in that regard. So again, thinking about the Maryland system's research activities, now, and again, if you talk to your compliance professionals there, they already know about this, but you now have to care about clear communication in research activities because of this change, and you see at the bottom of this kind of timeline, the revised common rule. The original common rule developed out of a lot of the transgressions from World War II and a lot of other research issues like Tuskegee, syphilis trial, and all of that. And the idea was the common rule would protect participants, but that didn't always work. There was still a lot of questions left to be unanswered, and you'll see from some of the guidance committees, the process of writing consent forms and obtaining consent has become stagnant and overburdened with competing purposes. With most clinical consent forms following the order of the elements. So people were just like, this is just a perfunctory, kind of ministerial task of let's just check this box, this box, this box, this box, and forget about how, if people understand. And then you get people like this, it was pages and pages of this could happen to you and that could happen to you. I didn't read one page. I just signed at the bottom and said, give it to me. And that's what the change in the common rule was meant to address, is this idea. There's a lot of things, really. There was biospecimens and other things that didn't exist in 1991. But at least from our purposes, we wanted to kind of move consent away from protecting institutions and being more what they're meant to do, which is informing people that they're going to be partaking in research. And so now the revised common rule has an understanding, what I call an understanding requirement. It requires that content, organization, and presentation must be clear and understandable. And the goal of this is to facilitate a participant's decision about whether to participate in research. And then there's the actual language. What's really interesting and setting a lot of folks, really concerning a lot of people, because we don't have any guidance on this, is consent has to begin with a concise and focused presentation of the key information that is most likely to assist somebody in joining a study, which is great. I love this from a health literacy perspective. But the compliance professionals in the room, if there are any, will be like, oh my gosh, this is causing headaches, because they're so used to doing it a certain way. And now you have to flip it on its head and say, there's not going to be one right answer to this. It's going to have to be study specific. And that is the part. The goal isn't to protect the institution, it's to facilitate comprehension. And so from an advocacy perspective, there's a lot of this that you can use to support your endeavors. There's always something, if you're at a major hospital, or if you're in a small group, you probably have some type of mission statement or policy statements, or kind of the ways of doing things, even if you don't want to think of it as formal. Those are the places to look for things that kind of connect with the social determinants and health literacy and all the things that you're trying to do. Because if you can align your change effort with some policy statement or regulation, that would even be better. Then you're going to get kind of that regulatory or legal hammer to kind of say, well, we got to do this. This fits what we're trying to do. So a couple of tips now as I close. So implementing health literacy change efforts, it's, getting people on board is really difficult, but so is implementing things. And again, one of the white papers that have been published in the past by the National Academies of Sciences, a roundtable on health literacy, which now has different names, but now it's that, and I'm on that, and Dr. Bauer has been on that in the past. But they developed the 10 attributes of a health literate organization, and that is a great document, of course. But they kind of break it down into kind of the foundational aspects and talk more about how do you plan, evaluate, improve? How do you include your consumers in this? And so it's a really good document when you're thinking about not only organization-wide change levels, but even if you break it down to more of a micro level, within a department or something like that, within an organization, you can still do these steps. So I think of these steps as kind of like, there's 3 stages. You got system-based policy changes. And so that's something that, as you start thinking about, the regulations, the policies, whatever it is you need to change to kind of support this in the future, because there's always turnover. And people leave projects or move to different universities or graduate or whatever it is. And so if you can implement some of the policy related changes, then that becomes a goal, no matter who changes, no matter how many times things change up. Then implementation, again, is tough, but that's the second stage. And then, of course, outcome measurement and iteration along the way. So kind of stage 2 and stage 3 is kind of you flap back and forth between them. And again, so if you think about how you do these things, you have to assess, you have to develop some policy, and then you have to, kind of enforce things, assure, train the workforce, evaluate. And so there's a lot of good resources out there. This is, again, from Dr. Rima Rudd from Harvard on the implications of health literacy for public health and how you make public health change efforts. So I thought this might help the white paper effort as well. And then one of the things I don't think gets enough attention is this Enliven organizational health literacy self-assessment. I think because it was created in Australia, that it doesn't get as much attention here in the U.S., but it relies on all the U.S. data and authority. And so if you look at it, it's kind of like the 10 attributes of health literate organization, but it has nice checklists and things to help you kind of focus on various attributes of promoting or promoting change within your organization. I think it works best for public health organizations and social service organizations, but there are other assessments that are developed, and this is easily tweaked as well. So with that, I will quit sharing my screen for now, and then we can move into Q&A portion. Let me see if I can stop. Hopefully, I don't ruin it. Okay, there we go. So thanks everybody for tuning in and listening to some lawyer yap for a long time. I could do it for hours.
Well, thank you so much, Mr. Trudeau. Our very own Jocelyn Wang will be facilitating the Q&A, but I just want to let everybody know that you can use either the chat to message myself or Jocelyn, or you can use the Q&A in the WebEx to ask us the questions, and then we will call upon you and help you ask your questions. So before we start, Dr. Chair, Dr. Bauer, do you all have any questions that you would like to ask?
Well, I enjoyed the talk very much. I've spent a large part of my career in the world of IRBs and the like, what you're suggesting is a way to get consents down from the usual 9 pages of undecipherable English into a useful document. I applaud. The one obstacle to that is external to the university as well, and that is that the evaluators, accreditors, the people who allow you to operate or not operate don't always keep up with that point of view, and they are still very checkbox related kind of people. You didn't have this in your consent, and therefore that's a deficiency. I just wonder if you have any ways to keep the federal government regulatory agents in sync with some of the things that you've proposed for the research component.
Yeah, we're working. That's actually what we work on right now. So I'm on the FDA's, or at least I was on the FDA's Risk Communication Advisory Committee, and so they deal with other things. But from a research standpoint, having the revision to the Common Rule and having the guidance from the Secretary's Advisory on Human Research Participation, I think has been a game changer in terms of getting these other organizations, to listen. Not only government organizations, but Smart IRB and some of these outside organization IRBs and sponsors. I've done a lot of work for sponsors on, they're coming to me and others like me and saying, well, how do we make our, create consent forms or create a template or create a process that facilitates understanding. And so that's one of the things I've been working on with our IRB here for 4 years. So it doesn't happen quickly, of course, but just kind of the training, look for these things. It's not just understandability, but like for one of the things I tell our major projects is it wouldn't be hard because we have a nice community outreach organization at our Translational Research Institute. It wouldn't be hard to get 3 of our community outreach members to come in and look at your at your consent or talk to you about why this might not work if you go out to this rural area of Arkansas. So to kind of get those people involved, this whole idea of participant focused research and kind of development of things. I think it's got momentum here. But yes, those are barriers that I think are going to fall by the wayside, particularly as the generation who is used to the old generation either A, gets used to the new things, or B, retires, and then the new people are just used to that. So it's kind of the system, this kind of this rollover that'll happen, in time.
And
But
if you bring the VA along with that, if you get harmonized of all those structures, that'll be a major accomplishment.
I didn't mention the VA on purpose, but you brought that up. Yes, that they can be difficult, but again, we have a good working relationship here with ours, but yet because of the state versus federal dynamic, it still causes some issues for sure.
So Dr. Gerald, one thing to think about is there's always a push-pull, right, between the institution and the regulators, which Chris knows well. So when I was on the federal side, I would have the conversations with those, employees in the Office of Human Subjects Protection, and they'd say, well, there's nothing in the regulations that prohibit institutions from doing that. And so you talk to the institutional side and they say, well, the regulators won't let us do that. So I think sometimes institutions do kind of have to push the boundaries a little bit because I think, we hear this also about lawyers. People say, well, the lawyers won't let me do that, right? And then you talk to the lawyers and they're like, hey, I never said you couldn't do that. So I think there is this push-pull all the time between those two sides that, if, as Chris has pointed out, we have a lot of those frameworks and foundational documents that maybe we could push a little bit more.
Yeah, and I've always found that most lawyers, I would say probably 90% of the lawyers I talk to, when you just kind of explain what it is you're trying to do, they'll help you get there. There are some that are just like, oh, I don't want to deal with this. They're not motivated into it. But most people, if they are, if they share your organizational goals, and are not just kind of, punching the clock and just trying to, make their job or life easier, are going to be fine. I've had some really good working relationships with our general counsel's office. I mean, we redid our advanced directive because that was kind of the goal. The goal is by 2025 to have every patient of UAMS have an advanced directive. Now, we know that will not get 100%, but we're trying to get as high as we can to that. But in order to do that, because we serve all of Arkansas, we had to get this into a level that was understandable for everybody. People could still have their own, but we wanted at least a fallback that somebody could just fill out and those type of things. And it needed to work with IT because it needed to be, the flag on the system needed to be brought up as soon as somebody comes in with a certain code and those type of things. And so it's possible, but it would not have been possible if we hadn't gotten the legal team on board and said, hey, this is what we're trying to do. Can you help us do this? So I think if you empower them to be part of the team, then it's less of a, oh, you can't do this, and more of like, let's figure out how to do this.
Yeah. And we have a question from Dominique, who is also a President's Fellow. She asks, how would you recommend that an institution begin to assess and improve their consent forms to promote patient health literacy, as in first or key steps you would take if charged with this task?
Yeah, that's a great question. And let me tell you, I've been working on that for 4+ years, and there's still things I find. So as a patient, for example, I went to our eye institute, and this is probably, this was last month, I think. Yeah, I think it was January. And, they have this, when you sign in, you sign this little, electronic thing saying you can general consent. And I said, well, I need to know what I'm signing. They didn't know who I was at the time, even though they're part of this. And they're like, oh, they just looked annoyed to give me a consent form. But then I said, you know what, this probably doesn't work well with COVID, but in other times you could just have a laminated consent form that you can hand people, they read it, and then you sign it. And so oftentimes it's this micro level of, different organizations. Like I've been working with the organization for 4 years. A lot of the consent processes are great, but that one slipped through the cracks and somehow. And so usually when you start, you kind of figure out, okay, well, who are the key players that need to be, that need to be on board? So if it's a medical situation, it's always going to be, you got to get at least one champion doctor on this. And again, most doctors, again, especially maybe the ones that also have public health degrees or something like that, they're going to get this. And if you get one champion doctor on board, then that helps you with a lot of the administrative hurdles. And of course, if you get an administrator on board, that's even better. And then from a research standpoint, you've got to work with the IRB right from the beginning. If you're trying to force changes to the IRB, it's never going to work. So a lot of it is the educating and kind of getting people, creating a team. And so team members, doctor, legal team member, general counsel member would be great. IRB if you're focused on research. And then, again, if you have patient advisory councils or some type of community resources, somebody from them needs to be part of that team as well, because they're going to give you a perspective that you don't have, because you don't know what you don't know, and probably just more than one, a couple at least. And so that's how I would start. And that's how I always start is who has to be on the team, and then get them on the team, tell them why this is important, hoorah, let's go out and win the game type thing.
Makes perfect sense. And then we also have a question from Everly Brown, who says that at UMB's Health Sciences Library, we have a service where we review consent forms and suggest edits to help lower the reading level.
Yeah.
And they get consent forms that are as long as 36 pages sometimes, and there seems to be a lot of cut and paste of language from the sponsor into the consent form. So why is that, and what can we do to help prevent this?
Well, you mentioned one word in there that gives me there's really two answers to that. And the one word that makes it two answers is sponsor. So you can but can't change the sponsor language. Institutions are worried to do that, and so they're not going to do that. But the good news is that people like Dr. Bauer and I and others like us are working with sponsors to make their standard language better. So I actually predict we're not going to get 90% saturation among sponsors, but the major drug development companies and device development companies, they're already working on this and making their standard sponsor language be clearer. So I actually think we might be faster getting the sponsor specific language clearer than we will the institution specific language. So with sponsors, there's not much you can do but kind of wait on that. But what I often say is, if you're trying to do this and you get some pushback about something, I generally don't fight it. I'm like, sure, fine, take this part, but let me change these other parts. Because oftentimes people, when they start thinking about one thing they don't like, they'll discount the whole document. And so if you can pinpoint what those things are and then give them those, then they're going to give you some other things. You're like, oh, you don't care about this? Let me deal with this. And so 90% of the document or 80% of the document is much better. But I also think you'll start seeing more national movements on things, especially as e-consent becomes more popular and more widespread. And I think that's going to jump leaps and bounds because of COVID. I mean, we're already thinking about like, we can't be behind on this. And again, that's been something I've been pushing for years, but just said, let's not worry about that. Let's get our paper stuff done first. And now it's like, we need to worry about that. And so once we get into e-consent, you can do so many more things. You can treat consent less like a document and more like a training module. You've got to go through this training module. And then, as you go through the training module, you're covering all of the regulatory parts. And so when you do that, it's less of a 3,000 word document and more like, oh yeah, over this course of a night, I went through these little modules, and so that might even be better because you can do a lot of the teaching and learning things that we've learned about pre and post, and to actually assess understanding and improve understanding. So I think we're going there, at least I'm going to help try and push that way, but it's going to be a little bit, a couple of years probably, if not longer.
Well, so that we are conscious of our time and respectful of Mr. Trudeau's time, as well as everybody else that is present. I'd like to thank you on behalf of the University of Maryland, Baltimore. I'd like to thank Dr. Bauer, Dr. Steins, Jocelyn Wang, Dr. Jarrett, and everyone to listen to this. It was absolutely fantastic. And so thank you, Mr. Trudeau, for joining us today.
Well, thanks so much for having me. And I'm really excited about, hearing about these type of change efforts. It's not easy, but these are the type of things that become case studies for others to follow. And so that's great.
We'd like to thank everybody for joining us. Please mark your calendars. You should see on the Elm, our next symposium is on March 8th at 4 o'clock. And so we're very excited that will be a panel hosted by University System of Maryland Chancellor, Dr. Jay Perman. And so we're very excited for that panel and to hear more about health literacy as a social determinant of health. And so with that being said, thank you all. And thank you, Mr. Trudeau.
Thank you for being here.
Thanks, everybody. Appreciate it.